Good afternoon, everyone. My name is Shannon Kupka from Comagine Health. I'd like to welcome you to our half-hour Hot Topics series. Our 2020 Hot Topics will explore CMS priority areas such as improving behavioral health and resident safety, reducing readmissions, opioid misuse and adverse drug events, infection prevention, antibiotic stewardship, and more. These webinars are designed to provide you great ideas on caring for your residents in a 30-minute time frame to accommodate your busy schedules. They're brought to you by the Comagine teams from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. A few housekeeping details before we start. Please take a moment to let us know who's on the webinar today by entering your name and facility in chat, as well as the names of any folks joining you so we have an accurate head count. Your cameras and microphones are muted. If you would like to ask a question, please enter it in chat and we'll facilitate a question and answer session at the end of the presentation. And please make sure that you're chatting to all panelists and attendees. We are very excited about our presenter today, who is doing a part 2 to preventing adverse events in nursing homes. Jennifer Pettis, MS, RN, CNE, WCC, is Associate Director of the Long-Term Care Program for Nurses Improving Care for Health System Elders, NICH, at the New York University Myers College of Nursing. Established in 1992, NICH is the leading nurse-driven program designed to help hospitals and healthcare organizations improve the care of older adults. She has extensive clinical, managerial, consulting and training experience, including as a consultant to the Division of Nursing Homes at CMS. Ms. Pettis received her AAS in nursing from SUNY Adirondack and both her BS in healthcare management and MS in nursing education from SUNY ESC. I will now turn things over to Jennifer Pettis, and let's do a quick test audio with the group. Can everybody, Jen, can you say hello?
Hi there, Shannon and everyone on the phone.
And could folks just chat a quick yes if you can hear Jen? All right, we got our first yes, so Jen, you may get started.
Okay, well, hello everyone and welcome to part 2 of Preventing Adverse Events in Nursing Homes, working together to keep residents safe. I appreciate those of you who are here with me on the first session and back to join again today. Here's our objectives for this half hour. I'd like you to be able to, at the end of the program, discuss how to use root cause analysis to investigate an adverse event, to explain how evidence-based practice can prevent adverse events, and that you'll be able to use the CMS trigger tool in order to critique a facility policy or protocol for high-risk medications as part of your QAPI process. So let's start by taking a look at root cause analysis, or RCA. Almost every team that I've worked with in nursing homes reports that they perform root cause analysis to identify underlying issues to address either at a resident level in care planning or a system level through QAPI. Unfortunately, there's a lot of variation in the proficiency with which teams perform root cause, so my hope is to give you some structured tools that you'll find useful in these processes, both at the bedside and as a QAPI team. So according to the Oregon Patient Safety Commission, root cause will help you look at systems in place in your facility and examine what made it possible for an adverse event to happen. Root cause analysis seeks to identify primary cause or causes of a problem so that you can determine what happened, determine why it happened, and figure out what to do to reduce the likelihood that will happen, that thing will happen again. And I think it's important to look at the root cause way and the old way, or traditional methods. So the old way, these traditional methods, we expected staff to perform flawlessly 24/7 and blamed staff when they didn't. This was focused on fault finding, not fact finding. We expected staff to adapt their practice to what equipment was available or our procedures in an organization. The process was the process, and staff should conform no matter how cumbersome that process was. And we also relied on chain of command in a facility to investigate errors and impose corrections. This is a top-down way to examine issues. And most significantly, in the old way, caregivers are punished for errors. On the other hand, root cause analysis encourages the development of systems that are designed to compensate for human limitations and looks to system fixes when an error occurs. Root cause analysis stresses the development of equipment and procedures that are designed for safety. Importantly, these are designed with the input of the people who actually do the work. Root cause analysis relies on teamwork among all staff to analyze problems and to propose and implement solutions. Everyone has a voice in the process, and each team member is seen as bringing a valuable opinion to the process. Root cause analysis stresses learning from errors. Root cause analysis also recognizes that adverse events usually result from a number of factors that are all part of the normal processes of providing care and service. There's rarely a single error made by one person that causes an event. Excuse me. So I'd like to share 2 root cause analysis tools. The first is the 5 whys. And the 5 whys is a question asking method that used to get to the root cause or causes of a problem. Team members should continue asking why until they've identified the true source of the problem. This must be understood before the team can take action. Remember, there can be more one root cause, so it's important that we keep asking why. I like this approach when we do things like a post-fall huddle or something when there's a resident issue and it's the team right around that resident that can kind of brainstorm together, and it's quick, this tool is easy to use, and the 5 whys allows the team, gives them the opportunity and the permission to share their ideas of why something occurred. And then when they give us that first why, we then say, okay, why do you think that thing happened? Let's continue to dig underneath it. So the 5 whys is a great tool. When it comes to QAPI and looking at systematic issues, I love the Fishbone Diagram. And I must say, for a lot of folks, this is scary at first. One of the things that I love it is it forces us to brainstorm to identify possible causes of a problem in all of these different categories. So the Fishbone Diagram is really a visual way to look at cause and effect. The value of this is that we dig deeper. We go beyond that initial incident report or that initial quality summary that we're looking at to better understand what is in the organization's systems and processes that are causing the problem so that they can be addressed. We begin the Fishbone Diagram by placing the problem in the head of the fish. You can see there at the end of the arrow. And then under each category of the fishbone, answer that question, why, for the identified problem. For example, ask, why are people the cause of this problem? Why are processes potentially a cause of this problem? And once your team has completed the Fishbone Diagram, discuss the various causes to get to the root of the problem. It's from this discussion that the Focus for Improvement plan can begin. I really think that a key benefit of this Fishbone Diagram is how it forces us to focus on these potential, these variety of categories. Again, for example, issues in the environment or equipment. I had the opportunity to go into facilities and work with teams to identify root cause around clinical issues with them across a given state. And we always pulled out this diagram and said, okay, let's start with people, and just took a whiteboard or a piece of a poster board or something, and just wrote down everything folks could think of. And we would usually fill a whiteboard or fill a chalkboard with ideas that might be causing the problem. And certainly you can't say we're going to address all of these as part of a problem, but we can identify what are perhaps the either the low-hanging fruit and easy to address early, or the things that we think might be the biggest problem, and we can address those first, perhaps what puts our residents or our organization at the most risk. So lots of good ideas there about root cause analysis, and I hope you consider how you can implement those in your facility, or perhaps if you haven't implemented them, strengthen them a bit. So in their study regarding factors contributing to serious adverse events in nursing home, Anderson and colleagues found that medication errors, falls, delayed or inappropriate intervention, or missed nursing care contributed to the vast majority, that is 89% of the serious adverse events. A total of 693 possible contributing factors were identified. The most common of these are listed on this slide: lack of competence, incomplete or lack of documentation, teamwork failure, or inadequate communication. My guess is that some of these don't surprise those of you who are on this call or this webinar, but they did find additional factors, things like failure to follow procedures, missed or incorrect clinical assessment, lack of management or administration, missed risk assessment and linking preventative strategies to those risk assessments, gaps in continuity, again, communication between care providers, and that's just a few examples against many others. But I think it's worthwhile to highlight the most frequent contributing factors to medication errors and to falls, because I think these two things are prevalent and really something that is often a focus of QAPI teams. When we look at medication errors, there were administration problems, so failures to follow policies with that, lack of competence, so the staff didn't understand, either didn't know what the medication was or didn't understand the correct way to give those, and again, just failures in administration. So overall, things were forgotten or otherwise not provided. And when we looked at falls, missed or incorrect clinical assessment was the #1 thing, and that was followed with incomplete or lack of documentation, teamwork failure, and inadequate communication. And I will tell you that I was preparing a presentation on falls, and really every guideline that I look at with those falls addresses the need to focus on assessment, to look at the potential for checking inter-rater reliability. So if I'm Jen, the nurse, doing one assessment, and my colleague Jeff, the nurse, is doing that same assessment on that same resident, are we coming up with the same ideas? And if not, we perhaps need to educate staff on really what those assessment parameters mean. And then most importantly, I think this really pertains to any risk identification tool out there, is we need to look beyond risk scores. We really need to drill down and take a look at what are those individual factors and then care plan around those individual factors. So I've been talking a lot for the last 10 minutes, and I'm going to take a breath and ask you guys to give me some input. I'd love to chat a little bit about near misses. When your staff says, whew, that was a close call. We're so lucky that something happened and that bad thing didn't happen. So a near miss or a close call is that event or situation that could have resulted in an adverse event, but it didn't. And again, it's either by intervention or you're just lucky. So how does your team identify and investigate near misses? Take a moment and chat that in. Make sure you're chatting to all panelists and attendees. And so how does your team identify and investigate near misses? And I'd love you to think about this question. What was the last near miss that your team identified? So we have here someone who does a team huddle after each fall and a root cause analysis for a recent elopement. Great. How about a near miss, though? That resident that made it to the front by the lobby and didn't make it out the door. Do folks go back and do a root cause analysis of those? One story that I often tell when I talk about, and I told you I was going to stop talking. Clearly that was a lie because I'm still talking while you're chatting. But there was a situation in a local county, to me, I live in upstate New York, and the resident had those big like bureau kind of closet things in their room, but it wasn't bolted to the wall. So the thing tipped over. It tipped over and the resident got injured. It tipped over a second time and the resident got injured again. And it tipped over a third time and the resident passed away. So the difference there is, what did we do? I mean, those weren't even really near misses. They actually tipped over. But how do we catch that? Here someone tells us about a nurse who nearly administered Novolog rather than Novolin. The second check nurse caught the error, as well as a 30-dose difference. So there you guys have a system of a second nurse checking errors. It's funny, I saw that happen in a local, not this scenario, but that idea of a second nurse checking the insulin in a local rehab center here near my home. That hadn't been something I had seen going on, but clearly places institute that when there's a problem often. So great. So near misses, it's all about investigating those. And I would argue that if you haven't investigated a near miss lately, chances are your team is not reporting them. Near misses are those things that give us a clue to say, we had this thing almost happen. How can we change our system? Amanda's story here about the insulin, when you look at how that was allowed to happen. So how the one resident almost get the wrong insulin, you can then back up to say, how do we get that wrong thing in that container or in that bunch of medicines for the resident anyway. So again, they give you the opportunity. Falls, here's someone typing in our falls meeting. We sometimes notice a near miss when we realize a resident who has fallen is at very high risk for injury related to the fall, even though they weren't necessarily a high risk fall. Great, so you guys are realizing there that if this resident does fall, it's very likely they're going to get hurt, even though we're not really, we don't consider them a real high fall risk. And I will share with you that in guidelines that I was reviewing, the nursing guidelines talk about, we're looking at who's gonna fall. We wanna decrease those falls, but we also wanna recognize those residents or patients who are most likely to get hurt when they fall, and make sure that we're trying to limit the level of injury for folks as well. So you are going to have the opportunity to chat again in just a bit, but thanks for those of you who provided some input. So you have that adverse event trigger tool. I'm pretty sure that Shannon put that in the, yes, it's right in there for panelists and or right in there in the chat. But we did look at the adverse drug event trigger tool last time that we met together as well. So nursing homes and leadership, including those in QAPI or QAI committees, might wish to consider how they can use this trigger tool in their efforts to improve quality of care, quality of life, and really making the nursing homes safer places, either to live or to get better to go home. The committee can use the surveyor probes as part of a proactive investigation of key systems related to high-risk medications. On our last webinar, we talked about what the 3 high flyers were. They are opioid medication, the warfarins and those types of anticoagulant medication, and diabetics meds. So diabetic meds, anticoagulants, opioids. Those are the 3 high flyers for meds. So if I was running the nursing home, I might be using this trigger tool. Me personally, I would start with the Coumadins, because I think that tends to be where we have found the biggest problems. The triggers on this tool are the signs and symptoms or clinical interventions, which may indicate that an adverse drug event has occurred. The committee can investigate any trigger to determine if the adverse drug event did occur, and if it did occur, then they can use a systematic approach such as root cause analysis to determine the underlying causes of the problem impacting the larger systems. The surveyor probes are questions that might guide the investigation of the adverse drug event. And following systematic analysis of that adverse drug event, the committee should develop a corrective action plan to prevent recurrence and to ensure sustained improvement resulting from that action plan, with ongoing monitoring, and to identify if either additional monitoring or new approaches. And I know we have about 12 minutes left, so I want to just spend the next few minutes sharing with you an example of using evidence-based pain management. So you're using your robust QAPI to ensure that your systems are safe. It's also a must that you use evidence-based practice on which to base your care. And just to change focus for a bit, we will talk a little bit about evidence-based pain management, and then also share an idea that I heard at last year's CMS quality conference that some of you guys have definitely heard about in the past. So evidence-based practice is comprised of 3 pillars: the best available evidence supporting what clinical approaches work and why, Clinical expertise, and this is an important one, including the experience and judgment that allows the nurse or other clinicians to identify and address healthcare needs, including by considering the risks and benefits of care and resident values and preferences. So you can think of evidence-based practice in long-term care really is an approach to doing, it's kind of the opposite approach to doing stuff because we've always done it that way, or rules of thumb, that's how it's always been. So evidence-based practice is all of that. I love to ask a room of people, on what do you base your evidence, on what evidence do you base your care? And I'm actually going to ask you guys that in just a moment. So when we look at evidence-based practice, there's really three cases that I like to make on it. And the first is population. The bottom line is people are getting older, and the old is a population that is growing rapidly. By 2060, we'll have 20 million people over age 85 and 600,000 folks that are 100 years old or older. Our older adults are also becoming more diverse. Folks with the older adults, as they get older, particularly as our population ages, we have more chronic conditions, and long-term care use, whether it's a nursing home, an assisted living, or long-term care services at home, or home and community-based services, will likely double by 2050. There's always a regulatory case for something in long-term care, and evidence-based practice is no different. We need to provide care as outlined by the comprehensive care plan that meets professional standards of quality. And how do we find these standards? Through current manuals or textbooks, standards provided by different organizations like the American Nurses Association or National Association of Social Work, clinical guidelines that are published by Agency for Healthcare Research or AHRQ or other organizations, and current professional journals. We also have a quality case for evidence in long-term care. There's no question that our resident populations have higher acuity than ever before. Our focus on providing short-term rehab has resulted in increased admissions and discharge and shorter lengths of stay for our residents. Consumers are better educated about care, and they have greater expectations, as do regulators and payers, around quality and safety. We also in long-term care have a blurred scope of practice between LPNs and RNs. This certainly varies greatly by state to state, but very often LPNs are functioning in supervisory roles, find themselves delegating to other staff, including other nurses and CNAs. And this kind of interchangeably of their roles can really influence quality of safety. So we have this case, these three cases for evidence, and let's look at evidence-based pain management just a little more. First, we are reminded that the goal of pain management is to maximize function and quality of life. Effective pain management generally includes a multimodal approach. It combines pharmacological and non-pharmacological approaches, and it's interdisciplinary. I am a nurse, no question about it, but I want to say that pain is not a nursing problem. Pain is a resident problem that needs a team-based approach. So I want to ask you guys just to chat for a moment, and I know we're running short on time, we have lots of info, but tell me, what evidence informed your facility's care protocol for pain? What guideline do you use? What non-pharmacological options do you have that promote resident comfort, that are readily available? So if I'm the nurse on the unit on the 3 to 11 shift, and I have a resident who's complaining of pain, what kind of bag of tricks can I look to help my residents feel more comfortable besides medication? And how are your interdisciplinary colleagues involved in pain management? So take a moment. You don't have to chat in for all three of these questions, but please chat in for at least one of these. So maybe the non-pharmacological options. What do you have that's readily available? I do want to mention that in response to keeping folks safe, that last question, one of our attendees said with new admissions, we do a 3-nurse check with new orders as well. We've had missed meds and orders in the past, and this has helped a lot, so that's great. And someone tells us they have massage therapy available. So I'm going to ask you to keep chatting in, and I'm going to keep moving ahead to talk to you about pharmacological. Oh, we have here warm blanket reposition, recliner rather than bed. Great. So lots of examples. None of those things are expensive or hard to provide. That's great. So again, keep chatting, we'll keep debriefing, but I want to move on and talk about pharmacological pain management. This is complex decision-making with lots of considerations. Pain management, pharmacological pain management certainly involves looking at the risk versus benefits, frequent reviews of drug regimens, and the establishment of clear goals of therapy. Older adults are at higher risk for side effects of drug therapy. And that's due to age-related physiologic changes. In other words, the mechanisms of drug action in the body changes. And as a result of these changes, several important recommendations apply. When beginning with medication treatment, always start at the low doses and then gradually titrate upward while monitoring and managing side effects. That start low, go slow is usually appropriate for older adults. Appropriate starting doses for older adults may be only 50% of the normal adult dose, and when possible, choose a drug with a short half-life and the fewest side effects. Use the least invasive route as long as the patient or resident is able to swallow. Oral is certainly the best choice. IV drugs may be helpful for acute or breakthrough pain, and generally IM injections are not the route of choice because they're painful. Pain prevention is highly recommended, around-the-clock dosing prior to painful treatments or events, coordinating with therapy and with activities and things to make sure that the resident has those doses when they're most likely to be uncomfortable, and that we're giving the next dose before the last one wears off. Some of the medications also have side effects, and effective pain relief is often accompanied by some of those less comfortable side effects. So we want to make sure we're co-administering medications or perhaps dietary interventions to minimize those. And that will be things like constipation, nausea, or itching. I do have on this next slide, and I know that Shannon's going to send out all of the references, some really great places to find clinical practice guidelines. I actually was on this City of Hope Pain Resource Center just yesterday, and it's really excellent. We want to make sure to communicate and educate with for our residents, families, and colleagues, promote the proactive use of meds, make sure that we're educating families and residents regarding their meds and the side effects, and working to be proactive with these. We want to explain and offer non-pharmacological options, tap into OT, PT, activities, social worker, all of our other interdisciplinary colleagues, and make sure that our staff has education about pain management. And I love this, the lessons learned from the ATOM Alliance. This was published or shared at the CMS Quality Conference, and the ATOM Alliance is another QIO, and they really focused on opioid medications, and their approach was pretty simple. They reviewed all current opioid orders, and to make sure that those orders actually identified the source of pain. So remember that pain is a symptom, it's not a diagnosis. They were focused on medication reconciliation during care transitions, reducing unnecessary opioid. They deprescribed when they could or replaced opioids with other interventions when possible. And they used a comfort menu, and I love this comfort menu idea. I talk about it often. The comfort menu is really pretty simple, but it was in these 5 categories. The first was sleep, and sleep would be things like a warm bath, music, sound machines. They used relaxation. That would be things like soothing sound recordings or a stress ball. Entertainment, talking visits, cards, magazines, books. Feeling better is this giant category with things ranging from chocolate to grooming options like brushing teeth or shampoo, deep breathing, prayer, sunshine, pastor visits. So the list goes on and on with that. And then comforter things like warm blankets, ice packs, handheld massagers. And you guys, when you chatted in, said a lot of these: repositioning, icing, warm blankets, recliner rather than bed. You guys are doing a lot of these, but imagine how good it would feel for your residents if you said to them, we know you have pain. Here's a list of all these non-pharmacological things we have to help you feel better. Tell us when you might want to take part and use some of those. And here is the CMS Adverse Events in Nursing Home page. It's part of the QAPI webpage. There's tons and tons of stuff there. And so at this point, I'm going to turn it back over to Shannon.
Okay, we're about to do some Q&A. So while you're percolating on some questions to ask Jen, I'd like to tell you about our new Comagine Health initiative. We're embarking on a partnership to reimagine healthcare, working with providers across all care settings on issues like improving patient safety, increasing access to behavioral health, addressing opioid misuse, and improving care transitions by reducing admissions, readmissions, and emergency room visits. Providers who join the partnership will receive expert coaching and technical support, education and resources, and will have access to their performance measures through our new interactive data portal. This is offered at no cost to you, and 400 of your peers across our 6-state region have already joined. Joining's as easy as clicking the link in chat that I've just put in there to sign up, or putting your name into chat for one of our team leads to reach out with more information. So if you like these hot topics, if you like receiving our email prevention gems and getting access to your performance reports, join us today. So with that, can folks please take a moment and enter any questions that they might have for Jen in the remaining minute. We're slightly over, but if you've got something that you'd like to pose to Jen while we have her, let's take advantage of this. And I've already also posted in our chat the link to our previous webinars that's in our nursing home libraries. So Jen, can you see the chat from Mariah?
Sure. So the question is, what is a snoozling room? And a snoozling room is all about sensory. It's about stimuli with sounds and lights and scents. So it's really not really a spa, but it's a soothing, stimulating kind of environment that allow again, usually subdued lighting, often colored lighting. There may be scents in there, music in there, just a really comfortable kind of room to get away from it all, that kind of focus that gives you something to see, to hear, to smell. And these are pretty popular with residents with dementia, in particular dementia or Alzheimer's. So it's really stimulating several senses.
Great. And we have another question about the trigger tool.
Do you have an example of system that work with the adverse trigger tool? I'm not exactly sure if I'm answering your question. If not, feel free to type in. But the trigger tool, how it is used in practice, it really is a surveyor tool. I had the opportunity to trial it in facilities, and we looked through resident records and looked at folks who were on, Coumadin was one we really focused on, or warfarin, and we really focused on those residents and looking back through charts and actually looking for those probes and looking at policies and procedures around that particular drug or protocols around that. And using those questions on the right side of the trigger tool that we would then examine policies and procedures. We actually did that as a big in-person in-service and had folks bring their policies and procedures. Jennifer asked, do we have, and if I did not answer your question, please let me know on the trigger tool. Feel free to try again. Does anybody, the next question is, do I have recommendations on how to get staff on board for evaluating a near miss? I think overall reporting, a culture of safety is what, and a culture of, what do I want to say? A culture of folks working together. Oh, that's what I'm looking for, just culture. The idea that staff are safe to bring these things forward is really the key to getting them to do so. You know, oftentimes if a nursing assistant brings something forward, they might get an answer from a charge nurse that says, we know, or yeah, we've heard about that, or they're always like that, or, well, did something bad happen? No, then we're good. So we need to get all staff that they have that culture of safety. And I always say a just culture is a piece of a culture of safety. A just culture is where someone can bring something forward without getting in trouble for it. But a culture of safety is inclusive of that, but I don't think it's equal to that, in that a culture of safety is really when we're looking at safety as a priority for everyone, and that begins with the top down. And there are lots and lots of tools about safety culture and just culture out there. Any
Great.
other questions?
Give you all about 10 seconds for any final questions, and you can always email this to one of your state contacts. We'd be very happy to reply with resources and follow up with your questions to Jen. So I want to thank Jennifer Pettis for a wonderful presentation again. It's been a delight to have you these past 2 months. And I'd like to invite folks on the call to please join us for our next Hot Topics, which is going to happen on March 13th, and it will be a presentation on opioid prescribing and safety. So this we've got a thank you for Jennifer, and so I'm going to conclude us for today, and this ends our Hot Topics session. I hope you all have a wonderful weekend, and please join us again in March.